As a refractive surgeon, I was terrified of lenticular extraction surgery. I was very reluctant to get out of my comfort zone of doing LASIK. But then I remembered these lines from John F. Kennedy. Change is the law of life, and those who look to the past or the present may miss out on the future.
The introduction of the ELITA femtosecond laser platform and the Silk procedure is an exciting new development in lenticule extraction surgery.
Let me share some surgical tips to shorten the learning curve and improve our post-operative outcomes.
Docking is a key step in ensuring a great outcome. It is essential to mark the limbus, center the suction ring, and then dock the ELITA system. The suction ring is held parallel in one hand while the gantry is lowered. Once it comes in contact with the suction ring, the ring is pinched to allow the gantry to drop into place. Once applanation is achieved, the lenticule profile can be centered on the center of the cornea or pupil to ensure a well-centered treatment. The number one tip prior to docking is to wet the ocular surface with a moist Vexel sponge. When the ocular surface is not optimized, meibomian secretions can lead to dark spots and areas where the laser may not fire properly. This clip demonstrates the presence of a tag that was difficult to dissect in the anterior plane. We tried to remove it with the forceps, but to no avail. A second swipe with the dissector was required to free the tag, and the lenticule was safely extracted eventually. Silk's biconvex shape gives great outcomes, but even surgeons who have performed lenticule extraction before may need to modify their technique a little bit. Remember, BSS is your friend. Keep the surface moist. Demarcate the length of your incision to understand how much area you have to dissect in. The key is getting into the anterior plane. In SMILE, the lenticule profile is plano-convex. In Silk, however, it is biconvex. It is therefore imperative to angle the dissector from right to left in an upward direction to access the anterior plane easily. Just as a temporal phaco-incision is made slightly superotemporal for surgical ease, the same way angling the dissector up at an angle helps get into the right plane. Angle the dissector down to the right to enter the posterior plane. Check the stop sign by feeling for resistance at the junction of the anterior and posterior separation. In case there is no resistance, there is a possibility that the anterior plane has not been correctly dissected. Sometimes the patient may move, as seen in this clip. In case the stop sign fails, it is important to be more careful during dissection. After the anterior and posterior planes are demarcated, a V is seen. Leave the point of the V undissected, as this can be used as a rescue area in case of a wrong plane entry. When the femto laser fires, a bubble is created in the anterior plane. If the anterior plane is correctly dissected first, the bubble disappears, as is seen in this clip. This is another sign that helps identify the correct plane of dissection. During posterior plane dissection, start paracentrally. It is important to wet the dissector. Dissect one side completely before moving to the other. Leave the 6 to 8 o'clock areas for last to avoid the lenticule folding over. If the eye is turned up towards the surgeon, the microforceps tends to slip under the lenticule as demonstrated in this clip. The animation demonstrates how the forceps fails to grasp the lenticule. A small tip that makes it easier is to get the patient to look slightly down. The jaws close around the anterior and posterior surface, and the lenticule is then extracted in a jiffy. The final steps of the procedure include ironing the cap towards the incision and surface hydration. In the initial few cases till the energies are optimized, OBL can appear and dissection can be challenging. If OBL appears, it is important to lower the anterior, posterior and the ring energies. It is important to remember not to use too much lateral movement, otherwise cap tears like the one seen in this clip can occur. In some instances, while trying to enter the anterior plane, inadvertent entry of the posterior plane may occur. If recognized early, the other side of the incision can be used to enter the anterior plane, and then the dissection can proceed normally. In this particular clip, posterior dissection has been completed. I am unable to grasp the lenticule with the forceps. The rescue maneuver is performed by using the forceps with an open jaw to tent up the anterior edge of the lenticule near the incision. The dissector can then be introduced above the area and the anterior plane can be dissected normally. At the end, the lenticule is examined to ensure that it is complete. On studying higher order aberrations with the iTrace system, we found no increase in HOAs and a reduction in corneal spherical aberration. The contrast sensitivity as measured by the iTrace was also well maintained. The LipiView and keratograph devices showed excellent preservation of the lipid layer thickness as well as the non-contact TBUT time. We also performed ocular surface imaging using our novel thermography device in patients undergoing LASIK and silk. Our findings suggested a better preservation of the ocular surface temperature and OSDI scoring in patients who had undergone silk.
I have gone from a surgeon who was extremely cautious about lenticule extraction surgery to one who is optimistic about the future of lenticule extraction procedures.
A smooth dissection is the key. Tent up to go anteriorly. Watch the stop sign and the victory V to extract the lenticule in a jiffy. Aberrations, dry eye and loss of contrast stay mostly away. Slow recovery no longer holds sway. Patients recover with a wow effect and say, "Doc, thanks for this. Have a great day."